Okay, so we'll go over alcohol abuse. Some of the things that I think going to be most important are going to be the signs and symptoms of alcohol withdrawal, knowing about delirium tremens, and then we'll go over some of the medication management. So that should help on preparing you on this part of the on this section over here. And then in general, substance abuse as well, with alongside some of the medications that will be commonly seen for treating substance abuse. Okay, so just going over the quick definition, uh, the definition of an addiction. So it's a medication causing addiction. It is causing either physical and or psychological dependence. So the difference between physical versus physiological. Physiological, it's literally just you have that desire to do it in order to feel more comfortable or in order to feel like you need to get high or you need to get take the medication or take the drug basically just in order to feel comfortable. It's just like a mental thing versus a physical dependence where your body will essentially go into withdrawal if you are not trying to use the drug, use the med. And that's kind of what we're going to go over here because a lot of the medications that um a lot of like in like the psych facilities I see a lot of detox we shouldn't have like where I work we shouldn't have like full on detox patients, but if they're already kind of like medicated or it's not acute, that can be taken care of, but otherwise they should go to like an ER. And I'll mention when we go to like alcohol withdrawal, some of the difference between like someone that is getting medication for alcohol withdrawal in the acute sense, like in the ER or on the floor, versus like outpatient versus like at a psych facility where they have to be medically cleared for first. But yeah, so physical dependence slash tolerance, that is all like the physical symptoms of it. Physiological is just like the mental addiction part of it. So, uh, yeah, withdrawal is going to be the signs and symptoms after stopping whatever substance someone has become addicted to. And it's going to be substance specific. So different substances are going to have different withdrawal symptoms. And one of the things that you'll see, especially with like alcohol, um, and like stimulants which are most likely to cause like the really heavy effects is that your body gets used to whatever effect those drugs are providing so that it kind of shifts as baseline, especially the ones that build tolerance really quickly will shift your body's natural baseline um in a way that without the drug you are in an abnormal state, and that's where the withdrawal symptoms come from. So for example, if we gonna go on like a number basis, like -1, kind of go like this. And if you say like your baseline is gonna be zero, everybody's baseline is zero. If you take if you take like alcohol, right? That's a depressant. We all know that's like a depressant. It'll put you like let's say at -1 or -2. In order when your body builds tolerance to it, what's essentially happening is that it's shifting your baseline to a higher number so that without the drug or with the drug, you become more back to that zero. So your body's trying to kind of go back to even with the drug, it is going to go back to like a baseline. That's what it's trying to do. So that's why over time, as you keep doing the drug, even though like the first time you were doing it, the first few times you were doing it, you were over here like with the depressant alcohol at -2, your body gets used to it. So maybe you start getting to -1 instead, or kind of like in between -1 and zero, so you don't feel that effect anymore, which makes you want to drink more, and then that kind of fuels the tolerance, it fuels the dependence and the addiction, which is why people are going to need higher doses of something to feel what they're feeling because their body is adjusting. But what does that mean when you are not taking the drug? So if you are taking so much alcohol that your body has adjusted to it to try to kind of reach that, go back to your baseline, even with the drug in your body. When you don't have the drug in your body, that means it's basically turning the baseline in the opposite direction, which is In this case, if it's not a depressant, it's kind of going into that instead of rest and digest, it's going to that fight or flight. So for alcohol withdrawal, like when you're taking alcohol, you go to these negatives, your body gets used to it, it shifts back to your baseline. When you're not drinking alcohol over a long period of time, your body will then uh, go into this side of it, like that stimulated, that fight or flight response, because it's so used to having alcohol in its system that without it, it's like overcompensated for the presence of alcohol. So if you don't have alcohol, you're gonna be back in like an abnormal part of it. So some of the medications that I think are good to know. So naloxone or Narcan. So Narcan, we know that it's going to be good for opioid withdrawal. So if somebody's respirations are too low, like less than 8, less than 10, depending on the facility, Narcan is something that can be used in emergency situations to reverse the overdose. And one of the most common ones that you'll see is like a nasal spray. So I can commonly given as a nasal spray every 3 to 5 minutes. And the good thing about it is that you can essentially just keep giving it. If it's not effective, you can keep doing it every 3 to 5 minutes. It's not something you can overdose on. It's not something you can go too crazy on. The side effects are minimal to none. So it's a very good rescue medication in those situations where you suspect an opioid overdose. And then that's kind of like an emergency, so I kind of highlighted that part there. The next medication that was highlighted is now naltrexone. Some of the brand names are listed here. I've never seen Rivia, but I have seen the brand name Vivitrol. But I've seen naltrexone used the most, just like the generic name. And I've seen Vivitrol. I've never seen Rivia, but she had it down as Rivia. But I think for the test, it should have both generic and brand name anyways. So for this medication, it's similar in the fact that it's an opioid antagonist, but naltrexone is used to more of prevent relapse, prevent the cravings, and it's effective for both opioid and alcohol use disorder. So naltrexone, you can see it for those that have a history and have a history of opioid or alcohol abuse. The way it functions, it by blocking the opioid receptors it will prevent those positive effects that people, want to take opioids or drink alcohol for. So it's going to help prevent the relapse. So you can kind of think of it as like this is for acute opioid use, and this is for chronic, chronic, less acute opioid use slash also alcohol use. It does have that benefit of that. So emergencies, and this is more like you can take this home and be on it at home or be on it at a low acuity facility. The next one that I see often is Suboxone. So this is the generic name. You can see that it includes the naloxone, the Narcan as part of the medication. So this one is going to have the naloxone, which you mentioned is an opioid antagonist, with the buprenorphine, which is a partial antagonist or a partial agonist rather, sorry, meaning that it is partially affecting those opioid receptors. So it's kind of usually I see this as a sublingual strip can be used as a sublingual strip, but I have seen it PO as well. And this one is going to help cravings, kind of like the naltrexone, but it can also help with withdrawal symptoms at the same time. So it's kind of like that two for one, which makes sense because it's two medications at once. So the antagonist part here is going to help reduce the cravings, while the partial opioid agonist part is going to help with withdrawal because it's going to partially give you some of the feelings that you would get from taking an opioid. The last medication is going to be methadone. You might have heard of this one. I don't think she has it listed down, but methadone is going to be a full opioid agonist. It is straight up an opioid, but it is something that can be given for more acute withdrawal patients. So this is, I would say, something that would be given to someone that is freshly coming off opioid abuse. And the idea would be that, they're going to be on methadone, and then over time, they're going to switch over to something that is a little bit less prone to abuse because this is still is an opioid, although not to the same level as like morphine or heroin, for example, but it is still going to have that same, going to trigger the same receptors. But because it acts slowly and it's like more like a longer lasting, it is less abusable, and it does help with opioid withdrawal. So, okay. Other things that I would say these are like the main things that are like abusable. You can also have some mentions of like things like nicotine, like smoking cessation medications. Um, but like what, like a common medication for to stopping like the nicotine addiction would be like bupropion, which we've talked about before. It has a lot of uses in like ADHD, uh, weight suppressant, can be used for anxiety, also is used for depression, but it can also be used to decrease the cravings for nicotine. And then of course people, go on like nicotine patches to try to prevent themselves from smoking, and then, kind of titrate down nicotine gum, nicotine lozenge. But that one's not as severe, so I didn't really include it. When it comes to substance abuse, something that I brought back up here from week one is going to be this bill that will become effective in January, so in 1 month from now, which is just the expansion of what it means to be gravely disabled. So we talked about it before. Basically, being gravely disabled will no longer just be inability to meet, the ability to obtain food, clothing, shelter, uh, as a result of a mental disorder. They will also now include take into account those with substance use disorders or those that are unable to meet their medical needs as well due to their mental health conditions. So someone that has severe alcohol, substance abuse history, or opioid abuse history, and it is suspected that they will kind of, if they are just go back to the streets from being discharged from a psych facility, that they will go back to abusing drugs and unable to take care of themselves based on like past evidence, they can be put on a hold, as opposed to before, where it'd be like, well, you technically have a safe place to go, and you technically have a safe way to get there. You can, in theory, obtain food, clothing, and shelter. You can, and then you can go. If it's suspected that that severe substance abuse disorder will get in the way of that, they can put you on hold. Or if you have some sort of medical care that you cannot meet realistically as you're out, as you're going out, same thing. I figured just because She brought it up. It might be like a test question. She might have added this as like as a test question at some point. So I just included it there. If not, it's like a fast reminder. Not too bad. And then we're going to focus a lot on alcohol abuse. So some of the medications that can be used for, this one is more like opioid abuse here. So we're going to talk specifically on the medications for alcohol withdrawal and alcohol substance abuse management. So some of the risk factors for alcohol abuse are genetic. Some people are just more prone to being addicted to certain things. Psychiatric conditions can also exacerbate the risk of becoming addicted to alcohol because of people's attempts to self-medicate. Very common, you know, we kind of hear like, oh, people who are depressed, they might try to drink to trying to get over, even though it is like a depressant. It will, it has like that euphoric part of it. So people try to drink to make themselves feel better. Trauma can make someone want to go into drinking, anxiety, and even like ADHD can make someone more prone to addiction in general. And then obviously social cultural, socioeconomic. So somebody that is struggling financially, someone that is just around a lot of people that drink might also be prone to becoming addicted to alcohol. Some of the common long-lasting effects, of course, cirrhosis, we all know that one. Alcohol can also increase your risk of certain cancers. So I just put that in there. Various cancers from alcohol, heart disease. There's one that is specific to alcohol, or one that's specific to alcohol abuse due to kind of what's mentioned here. When you're drinking alcohol, your body is also on top of like the liver not um, being affected due to the fact that that's what's going to be clearing it out. You're also going to have a harder time absorbing certain vitamins and minerals, so becoming malnourished or vitamin deficient is also a common thing. Consumption. So one of the ones that you might have briefly touched on is Wernicke-Korsakoff syndrome. So this is something you could see, or at least the thiamine supplementation is something that you could see on the medical floor too. So you might have a patient that is has like a banana bag or has because the acute withdrawal, alcohol withdrawal, you'll see on the medical floors more than the psych floors, because they're not medically stable, so they don't go to the psych ward. So you'll actually probably see something similar to this if you're working on the floor. Maybe not this exact condition, but the fact that they're getting supplementation. So yeah, because of the decreased absorption due to the alcohol consumption, having thiamine deficiency can lead to brain damage over periods of time. So you can kind of break it down into the acute versus the chronic. So older terminology, the Wernicke part of it was known as like Wernicke's encephalopathy. So encephalopathy, like issue with the head. In this case, it's referring to confusion. Basically, basically just acute confusion. Why is that mentioned? So yeah, so during a abrupt withdrawal, just happening during a heavy alcohol use or malnutrition due to the lack of thiamine deficiency, this is the acute part of the condition, which is confusion due to deficiency, which is why people that are heavy drinkers probably have thiamine as one of their daily routine medications just for supplementation. And then the chronic part of it includes like permanent memory damage, what they call confabulation, which is you have that permanent memory damage. Your mind makes up things to kind of fill in the gaps. Old terminology, course it used to be called Korsakoff's psychosis, but it's not psychosis. It's just you're making stuff up. Your brain is making things up to fill in for the memory gaps caused by that brain injury, that brain injury that's not like permanent brain injury. So it goes from acute here. You can reverse this if it's treated quickly and kind of avoid very permanent damage. But if it goes untreated for too long, then you start having some of this, or it's just constantly happening over and over again. Like it gets reversed and then it happens again, reverse happens again. Can have all that kind of happening there. I don't think you're going to be tested heavily on this, but I think it's good to know. And you might come across someone that is getting thiamine replacement, or they're like a history of alcoholism, and you're wondering what is the vitamin supplementation for? Because you'll probably get asked, and yeah, that'd be the answer for that. Okay, so the two important things here are going to be the signs and symptoms of alcohol withdrawal. So some of the things include being sensitive to light, sweating, fever, high heart rate, anxiety, tremors, increased blood pressure, changes in touch, hearing, and vision, and this can be hallucinations. Can be hallucinatory. So you can have hallucinations with alcohol withdrawal, headaches, nausea, vomiting, and in really bad cases, seizures. So some of the things you might have noticed is going way back to your second semester, kind of thinking about like hyperthyroidism, where things go, your body metabolism due to the thyroid hormone go up. So kind of like having everything in the body go up. Your heart rate goes up, your anxiety goes up, your respirations can go up, shaking. You can have uh, your your gut your gut movement go up, can cause nausea and vomiting. It's kind of the same idea because, like I said, if your baseline if your baseline is zero and you're drinking a lot and then you stop drinking, your new baseline is now is now like more elevated than it was before because your body is compensating for the fact that you're always drinking a depressant. So a lot of these symptoms are kind of elevated symptoms, so like almost like fight or flight symptoms. Um, so yeah, you see a lot of the fight or flight symptoms here, and then the hallucinations can also um, kind of be considered kind of like an elevated symptom. It's like a positive symptom if you kind of go back to the schizophrenia terminology, positive symptoms, things that aren't supposed to be there that are there because something is just very elevated when it comes to like the neurotransmitters. Uh, and then one of the, so this is like alcohol withdrawal. Even further than that is what they call delirium tremens. So this is going to be basically the same thing as this, but it is severe, very severe. It includes very profound confusion and disorientation, hardcore shakes, and goes harder into the delusion, paranoia, hallucinations aspect of it. And then kind of going down here, we kind of go over like the Siwa scale. You don't have to memorize the Siwa, but it does help looking through this to uh, kind of like as a review for what kind of signs and symptoms you're kind of looking for. And usually in the ER or in the floor, on the floor, if someone's having alcohol withdrawal, uh, the Siwa scale will be tied to PRN medication. So, for example, someone could have a Q4 Siwa scale, and the idea is that every 4 hours you're going in there and you're seeing if what their Siwa score is. So you're going to be, asking these questions. And the thing about the Siwa scale is that it even comes with like, what can you ask them? What can you tell them what to do in order to assess it? So here we can see nausea, vomiting, like which one, and it's kind of subjective to a degree, of course, but it does have pretty solid definitions and like kind of make your own observation like that. So we see nausea, vomiting, we see tremors, sweating, anxiety, agitation, tactile disturbances. So this could be feeling like bugs are crawling on your skin, hearing voices, visual disturbances, uh, it could be visual hallucinations. It could be um, like I said, auditory, visual, tactile, and then headache, and then overall orientation. And kind of like it mentions here, scoring less than 10 don't usually need medication for withdrawal, but in the scenario where they do, it's usually like IV Ativan, which is what we'll go kind of talk about. And it makes sense to use, a benzo because benzos are going to be CNS depressants, strong CNS depressants. And again, what's happening here is that your body's so used to a CNS depressant that it's becoming elevated. So that use of a CNS depressant to treat alcohol withdrawal is they call that like a substitution therapy, meaning that you're substituting the CNS depressant of alcohol with the CNS depressant of benzodiazepine to kind of bring back the body to its baseline. That's baseline that has been created due to the addiction, due to the tolerance. There is also something called the cage, but this is I don't you really don't need to know this at all, the cage. But it's for the testing at least, it's basically just something that like an outpatient family doctor or family NP would ask in order to determine if they need further evaluation. And it's basically just questions for like kind of determining dependent on alcohol. Like, have you ever felt like you should cut down on drinking? Have people been annoyed by you drinking? Have you ever felt guilty about drinking? Do you usually drink to calm yourself down? If they answer two or more, then more evaluation will be done. But for the most part, and again, you don't have to memorize either of these scales, but the SIWA scale does help to kind of get an idea of what you're looking for when it comes to alcohol withdrawal. And then going back down, now we have the medications. I do think this is important as well, even if not for this upcoming quiz for your farm. So you have your benzos, the way to tell them apart. They usually end in PAM or they end in Zolam. Some, exception would be this one right here, but we'll talk about that when we get there. Like I said, there's CNS depressants and it's what's called substitution therapy because you're substituting CNS depressant for CNS depressant. It's going to help with those fight or flight symptoms. It's also going to help prevent seizures, which is we mentioned was going to be um, a possible side effect. So some of the medications that you'll see, especially if you are on the floor, you're going to see IV Ativan, very common. This is going to be for short-term, just management. It's going to be used inpatient. Once that acute withdrawal is kind of managed, they could taper down to um, either inpatient IV diazepam, which is more of a long-term use medication. So like inpatient, once the acute symptoms have been dealt with, you can get IV diazepam to just kind of have a more like a long-term treatment. And if they're outpatient, you'll see Librium instead. So a PO of Librium, which is kind of similar in with the diazepam that it's used for long-term. So it's not going to be like the fastest acting. Diazepam is actually pretty fast acting, actually. It's fast acting and long lasting. Librium is more like a moderate moderate acting, long lasting, but it's also PO. So the difference would be, of course, that you're not going to give IV meds outpatient. So once they're able to go outpatient, leave the hospital, manage it on their own at home or at an assisted living or at a SNF, I suppose. the Librium by mouth is going to be kind of the medication of choice, and it's going to be tapered off because the idea is that you're not going to be relying on these medications your entire life. You're just going to get over the withdrawal symptoms, go to like Alcoholics Anonymous, therapy, whatever you're gonna need, or maybe naltrexone, like we talked about over here, which can be used to prevent alcohol use relapse. Yeah, we're here, and then taper it off slowly. So over time, maybe they get like a few doses, and then you decrease, and then decrease the dose, a few more doses, and then you're done with the taper. Yeah, because you're definitely not gonna kind of continue these for too long. It's just going to be a taper. Here's the naltrexone again. Talked about that previously. Thiamine slash multivitamin supplementation. Again, to treat the thiamine deficiency that can happen, which like I mentioned, can lead to the Wernicke's. For first line medication, why would they use Ativan over Valium? I think it would just be the idea that I mean, I guess you could say that the Valium is more for like chronic use. Ativan's more for like immediate use. I know that this one does work faster, but in terms of the way it kind of functions on the body, it's like a long-term med versus the Ativan, which is meant to be a short-term medication. So even though this one can technically start working faster than the Ativan, it at that time they don't want to necessarily use the longer term one just in terms of I guess potency. I think it has mostly to do with the short lasting versus long lasting effect of it. Yeah, for someone that is like acutely in the hospital, I can add some more information. That I looked it up just to make sure that I'm not making stuff up. So another part of the reason why it can be preferred is because it has more it's less hard on the liver because it's not it's like you give it and then it doesn't last as long versus diazepam, which lasts a long time. So we can say, of course, this is again just kind of fast acting, long lasting. I would say very long lasting. Diazepam, this is like moderate acting, long lasting, and Ativan is, I would say moderate. I would say short, to be honest. This this one looks very short acting. Has I would say less harmful to the liver and more predictable in an acute setting. So from what I see, the rationale in the acute sense would be more predictable overall. So this is someone that's going to the ER. Sometimes alcohol withdrawal is not the only thing they're going through. So having a medication that's more predictable and is not gonna kind of sedate them for long periods of time could be better to kind of see how their condition is going. Because sometimes the sedation could just hide a lot of other things that could be going on. Because alcohol withdrawal might not be the only thing that's happening to the patient. So having the more predictable short term, um, more predictable short term can help you see what else is going on. Otherwise, they might just be too sedated. Or if they're more like medically complicated. So somebody that has like liver issues or is like older, for example, maybe they're going to be on Ativan and maybe they don't even get put on IV diazepam. Maybe they just get tapered off Ativan, like a ta Ativan taper instead. Or they go for a different, or they just go for Librium, right, instead of, even in an inpatient, just because of the impact to the liver. And it's again also more predictable. So that's kind of, I guess that would be the reasoning for that. So on the floor, you'll like your CWO orders will be based on Ativan, and then from there on out, once they are ongoing, need long-term benzos instead of like a quick every 4 hours Ativan. They'll switch to one of these. I can put that here. Right on the liver. Okay. We talked about naltrexone, Vivitrol. We talked about thiamine deficiency for Korsakoff. This one I honestly haven't seen ever. The nalmefene, the Revex, but it is listed as one of the meds on the lecture, so I included it. This one's going to be similar to the naltrexone. They're both opioid antagonists to reduce cravings. Although from what I see, because not every drug works the exact same, it the naltrexone is going to be help to re is going to help with the relapse. So like once they're off alcohol, help to prevent relapse. While the looks like the nalmefene is going to be better for weaning people off alcohol. Still reducing cravings, but weaning off helps assist weaning off. While this one's just relapse. And then the last one would be the sulfiram, also known as antabuse. This one is used as a deterrent to drinking. This one is not there to prevent you from relapsing. This one is there to, as you can see here, when you are on this drug, drinking alcohol would cause you to have nausea, vomiting, flushing, palpitations. So the idea is that, you don't drink heavily. Once you're on this, like you have consequences to drinking now. So that's kind of why it kind of prevents the person from drinking because if they do, they might have it so severe that they have to go to the ER. So this one requires a lot of patient education. Be like, hey, if you are on this medication, it literally means that you should not drink or you could be going to the ER because it will make you have all of these symptoms. So that's something that I think could be like a test question. Be like, if they're on this medication, it should not be it should not be like you're weaning off. It should be like you are just not drinking anymore at all. Like this is not used for cravings. It's not used for weaning off because if you drink at all, you're gonna have these symptoms. And then last thing you can really do is just patient education. So therapy is essentially something you can do. Alcoholics Anonymous groups, and also very important the nutrition because so alcohol impairs. So, they could become deficient in thiamine, they can become deficient in vitamin B12, is a common one. So going all the way back to like second semester, I think it must have been going over like anemia, vitamin B12 anemia without it being pernicious can be caused by from alcohol abuse. because it can impair the absorption. So I'll include thiamine, vitamin B12, common ones that become deficient in, and it can have a lot of negative impact if you are deficient in them. And then counseling is kind of like the other thing you can do, which is basically therapy. And basically just coping skills, like what can you do if you are getting cravings? Just kind of distractions. I mean, obviously every person is different and these might not help whatsoever. Of course, like people can stop themselves, can kind of wean off alcohol on their own without medications, but depends on the person, depends on how much they've been drinking, depends on how their body tolerates not drinking or weaning off. So everyone's different. These coping skills might work for some people and it might do absolutely nothing for some. But that pretty much covers that. Any questions on anything? 'Cause this is actually a pretty short section. And then next week you guys just have like crisis, abusing crisis. And then that's pretty much it. You guys are done.
Are you going to do a session for abusing crisis?
Yeah, next week.
Okay, thank you.
Yeah. I'm not sure if it'll be Monday. Oh, when I guess I'll check your schedule. When do you guys have your quiz? Because the only thing, because I know Mondays are fine because you guys have Sims only, so most of you have off. Mondays I work, so like right now after I get off this, I'm gonna go work at 7. That's the only bad thing for me, but I think otherwise it's fine. But if I could get away with not doing it on Monday, I probably would. Let's see.
Next Monday, we have our Kaplan,
Oh, you have Kaplan. Okay,
but it's in the morning, I believe. I don't know, something like that.
gotcha. What I could try to do. You guys are short on. You guys don't go for too long. I could try to do it on Sunday. I don't work this Sunday because it's still after. It would be still after your lecture, so I am allowed to do it, and then it would be before your Kaplan. And you guys don't stay until. You guys definitely only stay like 4 hours at clinicals or 5 hours. So it would be. Oh, actually, the problem with that is that Saturday, Sunday they close. They close at 3. Well, that kind of sucks for. That would suck for lab group B. Friday, I think they close. I think they also close at 3, maybe. That's kind of what sucks. That we have to do it through the Student Success Center. Well, what do you guys think? Do you guys think I should just do it on Sunday or Saturday, whichever? Any of you guys here? Because I know you guys are basically the regulars. Um, any of you guys here have lab on Saturday or Sunday, and then specify which day? Because I might just do it Saturday so that because it's recorded. Because it's recorded, even like the people on Saturday could watch it on Sunday or whatever. Okay, yeah, so I think I'll just do it on Saturday then. That way, you guys have it before the Kaplan, then you're good to go. I'll stop recording for now.